Hello, this PowerPoint presentation will be on drug therapy in rheumatoid arthritis. Drugs used for rheumatoid arthritis. First, rheumatoid arthritis is an autoimmune inflammatory disorder, so the treatment is aimed at maintaining joint function, minimizing the systemic involvement, delaying progression of disease, and also using non-drug measures such as physical therapy can be very helpful. The major classes of anti-arthritic drugs include NSAIDs, DMARDs, non-biologic and biologic, and glucocorticoids. For the NSAIDs, you have the first generation, which inhibit COX-1 and COX-2, second generation, which selectively inhibit COX-2. An example of that would be Celebrex. And with all NSAIDs, you have to worry about thrombotic events and GI irritation, ulceration, and bleeding. Next, when you use glucocorticoids, you're going to use the oral formulations for generalized symptoms. For actual joint pain, you can use injections. You will expect the same types of adverse effects that you would anytime you use these glucocorticoids. And for oral administration, mainly your prednisone preparations. There are DMARD1 category non-biologics, and main meds here would be methotrexate and sulfasalazine. Methotrexate is the most rapid acting DMARD. Its therapeutic effect takes place in 3 to 6 weeks. Has serious side effects potential such as hepatic fibrosis, bone marrow suppression, GI ulceration, and pneumonitis. Sulfasalazine is used for RA, and it's also used for inflammatory bowel disease, so that it has anti-inflammatory and immune modulating actions. It can slow progression of joint deterioration, but the GI side effects with this may be intolerable, and so probably won't be your first line of medication for the patient. There's a list of other DMARD1 category non-biologics, and some of those I'm sure that you've seen before. Plaquenil is one of the older meds that are in this category for use, as well as cyclosporines. For the DMARDs2, those biologic DMARDs, those work by neutralizing or suppressing the immune function. These meds, probably the most widely known would be Enbrel. So if we look at Enbrel, we see it activates the tumor necrosing factor. It is used for moderate to severe RA. So you would find Enbrel used, and most of these meds for that matter, in specialty practice for rheumatology. The adverse effects are serious infections, serious allergic reactions, heart failure, hematologic disorders, liver injury, and CNS demyelinating disorders. Here are some of the other biologic DMARDs that are in use, and we've all heard of Remicade, I'm sure, Humira, as two that we would know, even if you're not working in rheumatology. And so, in closing, I just want to say most of the medications here are used in specialty. Many of those are in an injectable or an IV infusion. So having extensive knowledge of these meds would not be common in a primary care practice, but if you are going into that specialty, or you may receive your patient back for their primary care when receiving this from rheumatology. So it's still important to know, um, be aware of them and of the side effects that are potentially possible. Question number 1, a patient with rheumatoid arthritis is taking high-dose aspirin and complains of gastric upset and pain. What would you anticipate being prescribed for this patient? And the answer is C, the Celebrex. So what you would do is take the patient off the aspirin, place them on an NSAID with the COX-2 inhibitor. Question 2, patient with rheumatoid arthritis is prescribed methotrexate. When will you expect a therapeutic effect? And the answer here would be B, 3 to 6 weeks. And question 3, which statement about Enbrel does the nurse identify as true? And the answer is B, that it can cause liver injury. And that is it for this presentation. Thank you very much.